like you? I know that's what you're all thinking right now. As soon as I walked out here, you were sizing me up and assessing me, and you were trying to figure out, am I the kind of person you might like? And now you're going to argue it's more complex than that. You don't just want to know if you like me. You want to know, am I trustworthy? Will I be informative? Could I be inspirational? Maybe I'll be underwhelming. You're trying to figure out if the information that I'm going to present to you tonight is going to have any value in your life. Is it going to be worth your time? Because your time is valuable. What I would suggest to you is that whether or not this information that I'm going to share with you this evening over these next 10 minutes, whether or not it's valuable to you, whether or not it might impact your life in some way, change the way you think about something or the way you do something, it has a lot to do with whether or not you like me, the person presenting it. Now, this was not a lesson that I understood when I embarked on science communication as a discipline. I am a family doctor and I teach at the medical school, so I'm used to lecturing to students and residents, and I'm very comfortable with that kind of science communication. Basically, it's pretty straightforward. I have an audience of students who are seeking degrees in the sciences. I know the science, so we're kind of speaking the same language. That's simple enough. And the second part of that is that I know what their goal is. The goal of the students in my class, the goal of the residents who work with me, is to know what I know so they can do what I do. That's very straightforward. That seems simple enough. But when my husband and I started a medical history podcast, that was a whole different kind of science communication. First of all, I couldn't assume that my audience had any scientific background necessarily. They might, but I couldn't assume that, right? So I could use my expertise as a physician to untangle something, but I had to be really careful about the language I used and what I assumed about the person who was listening. The second part of that was maybe even more challenging is that the goal of my audience was very different from my medical students. They wanted to be entertained. This was a comedy podcast. It still is, I think. And so we had to be entertaining, which luckily that's largely Justin's job. I don't have to do that part. But what I did have to do was provide the information. That was the other goal. People listen to the show because I think they want to learn something. So I had to bring the facts, which is exactly what I started doing when we started doing the podcast. I would pick a topic from medical history, a diagnosis or a treatment or even a person, and I would diligently research it, learn all the facts, trace it back to its origins. When did it start, and the wheres, and the whos, and the whys, which I will tell you the whys are often so wild. And then I would bring it up into the present day, and I would share sort of a, here's what we do now, ending to the show. And all along the way, Justin would make very funny jokes about the material that I was presenting. And I like to think of these early episodes as kind of my historical survey episodes, and they were fine. People listened, so I assume we were achieving goal number one. They must have been entertained. Either that or they were gluttons for punishment. And then I know people were informed because they would send me emails and say, hey, I won a round of pub trivia because of your show. So that's great. We were succeeding. We were achieving our goals, and people listened to the show. And that was really all I set out to do initially. And then something changed. Many years back now, it feels like. We've been doing the show since 2013. We did an episode that I titled The Gut Hole Bromance. And if that sounds confusing or off-putting, sorry. And I am also here to tell you that most of medical history is confusing and very off-putting. But the story of the gut hole bromance is, and let me set the scene, we're on Mackinac Island in the early 1800s. There is a Canadian fur trapper who is in a general store when a shotgun accidentally discharges and he is struck in the stomach. A surgeon, Dr. William Beaumont, rushes to his side and over the course of weeks tends to his wounds and manages to save his life. But in the process, Alexis also develops something that we call a chronic gastric fistula. Now, what does that mean? He has a little tunnel that goes from inside his stomach to the outside world for the rest of his life. So he always has this hole where you can just poke right into his stomach. So Dr. Beaumont, who has saved his life, also sees an opportunity here. He could study gastric physiology and human digestion in a way that had never been done at that point. And that's exactly what he convinces Alexis to do. So over the course of their entire lives, these two men would get together. Dr. Beaumont would do some experiments on the fistula, basically by dipping little pieces of food in there, leaving them for a while, and then pulling them back out and documenting his findings. They would have some sort of falling out inevitably, and they would part ways, and then they would get back together several years later and do it again. This was their entire lives. And eventually Dr. Beaumont would become the father of gastric physiology, as it were, by publishing his findings. So this is a great story, but when I read it, what I thought was, this is a rom-com. This is like a classic will they, won't they. These two guys are like the Ross and Rachel of gastric physiology. And so when we shared this story on the podcast, that was sort of the narrative I put on it. I didn't change the facts. I didn't say this was true. I said, here are the facts, but here's how I see it. Here's my imaginary story around it that I was imbuing with my personality and my sense of humor and sort of revealing a little bit of who I was. So that was the episode we did, and the response was very different. People weren't just listening. They were starting to engage with our show, sending us emails and social media messages and even physical letters to our P.O. box. They started to engage not just with what we were talking about, but with who we were, who I was as a person presenting that information. And the more episodes we did with that sort of narrative and some emotion and some personal feelings about the content, the more engagement we got from our listeners. And I thought, this has potential to do something maybe even a little better than making people laugh, which is also a great goal. So we started shifting our show to also do something different, which is maybe impact people's behavior in the health space and public health care a little bit with the content that we provided them. And the way we did that is that we started tackling topics that I had shied away from before. We started talking about modern pseudoscience, sort of the snake oil salesman of today. We started talking about topics that were maybe controversial or politicized science topics, with the thought that if I can not just untangle it and share the cold, hard facts, but also my feelings and my emotions and my reactions to that, and then layer over that personal stories from our own experiences, both as a doctor myself and then both of us as patients. When we talked about the dark history of psychiatric care in this country, we talked about our own mental health journeys. When we talked about issues with maternal and fetal medicine in our country, we shared our own birth stories. And when we talked about vaccines, we asked listeners, send us your worries, send us your fears, send us your reasons why you're afraid to get vaccines, and let's talk about fear and worry. Let's start there, and we'll build to getting the vaccines. And this was so important, not only because we were and continue to be at a time when finding objective truth and knowing how to communicate scientific fact in a clear way is becoming increasingly difficult, but this is when we entered 2020 and the COVID pandemic. And at that point, I didn't have the cold, hard facts to hand my audience. I didn't have the answers. I couldn't bring them a big stack of evidence because it didn't exist yet. Medical history was unfolding around us. But I did have the trust of my audience. They knew me. They liked me. And so when I did my best to advise them that I think we should wear a mask right now, they sent us pictures of them wearing masks. When I told them that I think they should get the COVID vaccine, they sent us pictures of the Band-Aids on their shoulders. And since then, we've received, I can't tell you, countless emails and social media messages of people who have gotten a vaccine or donated a pint of blood or gone to talk to a doctor about a problem that they were scared to talk about before because of our show. So what I have learned about science communication is that while we are trained to bring the facts, give them the logic, back it up with the studies, and let them make the right choice, that's not enough. No one ever got a vaccine because you argued them into it. The truth is, the people who have been peddling misinformation and pseudoscience have been using this for a long time. They use narrative and personal story and anecdote to convince people of something that might not be true. We need to use narrative and personal story and anecdote and emotion to connect with people and encourage them to make good scientific healthcare decisions. Because the truth is, none of us like to get a shot. But if you've all decided that you like me, the person advising you to get the shot, there's a chance you might just roll up your sleeve and do it. Thank you.